So our next discussion is going to be about HPV vaccines, and Dr. Szilagyi is going to start us off.
Good afternoon. So it's my pleasure to introduce the HPV vaccines session. So a new issue is being considered by the ACIP HPV vaccine workgroup, an application to expand the age indication for 9-valent HPV vaccine through age 45 years in males and females was submitted to the FDA in April 2018. And I just want to remind you that the current licensure by FDA is through age 26. The FDA accepted the application and will give this a priority review. The focus of this HPV session is to begin the evidence review for policy considerations. Now, before I review the agenda for today's session, I want to review the past ACIP meeting back in February 2018 and the work of the workgroup. The HPV vaccine session at the last meeting focused on two issues. First, we presented an update on post-licensure HPV vaccine safety, specifically for the 9-valent HPV vaccine. The workgroup and the Immunization Safety Office at CDC periodically updates ACIP on vaccine safety, and this was the first presentation of the 9-valent HPV safety data to ACIP. And in the second part of the session, there were presentations related to harmonization of the HPV vaccination age recommendations for females and males through age 26. The workgroup had been considering this issue, preparing to bring this to ACIP to vote. Presentations included a review of the burden and trends in HPV-associated cancers in males and females, the epidemiology of HPV infection in males, and workgroup plans. The ACIP HPV vaccine workgroup was informed about the application for the age expansion after the February 2018 ACIP meeting. And workgroup calls have focused on background information related to the expanded age. Now, I want to emphasize that there's strong support on the workgroup for harmonization, and harmonization will be part of considerations going forward as the workgroup considers the evidence for the expanded age indication. So the agenda for today is a review of the background, and Lori Markowitz will give this, a discussion of HPV vaccine in mid-adults with results from clinical studies, and Dr. Luxemburg will present that information, and then considerations and workgroup plans by Lori Markowitz. And as always, I want to thank the large HPV vaccine workgroup, the ACIP members, Cindy Pellegrini and Jose Romero, the ex officio members, liaison representatives, consultants, CDC contributors, and most importantly, our CDC lead and expert, Lori Markowitz. So Lori will kick off the next session.
Okay, and so in this talk, I'm going to give the background related to the application for the expanded age indication for 9-valent HPV vaccine. And I'm going to address two areas. The first is to give some information on the U.S. HPV vaccination program as well as vaccine licensure related to this application. And second, to give a very brief overview of some of the clinical trials in persons over age 26 years. And Dr. Luxemburg is going to review these in more detail. This slide is just to remind everyone about the evolution of the vaccination program in the United States. Quadrivalent vaccine was licensed and recommended for use in females in 2006. The bivalent vaccine was licensed and recommended for females in 2009. And while the quadrivalent vaccine was licensed in males in 2009, it was not until 2011 when it was included in the routine program. In 2015, 9-valent vaccine was recommended for females and males. And at that time, it was recommended that any of the three vaccines could be used in females and any of the two vaccines could be used in males, quadrivalent and 9-valent. And then we had the two-dose schedule in 2016. So at present, three vaccines are licensed in the United States. The bivalent, produced by GSK, which is licensed for use in females 9 through 25 years. The quadrivalent and the 9-valent, produced by Merck, that are licensed for use in females and males 9 through 26 years. In terms of availability, after the end of 2006, only 9-valent vaccine has been available in the United States. and bivalent and quadrivalent vaccine continue to be available in other countries. The current recommendations for vaccination in the United States: routine vaccination at age 11 or 12, and the vaccination series can be started beginning at age 9. And vaccination is also recommended for the following persons if not adequately vaccinated: females through age 26, males through age 21, men who have sex with men, transgender persons, or persons who have certain immunocompromising conditions through age 26, and males age 22 through 26 may be vaccinated. So again, as you just heard, the manufacturer filed a supplemental biologics license application in April to expand the age indication for 9-valent vaccine through 45, and FDA accepted this file and will give it a priority review, and we expect the review to be complete by early October. And because data for the quadrivalent vaccine efficacy trials are going to contribute to the 9-valent application, as Dr. Luxembourg will discuss, I want to review briefly the quadrivalent trials. Trials have been conducted among females in 2 age groups. The first trials were in females 16 through 26 years, and data from these pivotal trials, along with immunogenicity data in 9 to 15-year-olds, led to licensure of the vaccine in females 9 through 26 years in 2006. A trial was also conducted in females 24 through 45, and in 2008, with these data, Merck submitted an application to FDA for an expanded age indication in females through age 45. FDA did not approve the expanded age indication at that time, but did allow data to be included in the label. And the reasons for lack of approval included lack of statistically significant efficacy for vaccine type-related cervical interepithelial neoplasia grade 2 or worse, and more cases in the vaccine group than in the control group in an intention to treat analysis regardless of HPV vaccine type. And on further analysis, this was considered to be primarily caused by an imbalance of infection and disease at randomization. In 2009 and 10, while FDA was reviewing this application in mid-adult women, the ACIP HPV vaccines workgroup considered data and options for use. But after the FDA decision in 2010, we did not bring this forward for a vote. This publication, however, shows some of the issues that were considered by the workgroup and ACIP. And as a reminder, at that time, the vaccination program in the U.S. was focused only on females. Quadrivalent vaccine was the vaccine being used in the United States. And the vaccination program was less mature, less was known about HPV vaccines and about natural history. Some of the issues that we reviewed in 2010 will be reviewed again for the current policy considerations. So while the age indication was not extended, as I mentioned, information on quadrivalent vaccine in mid-adult women are included in the quadrivalent label. This is found in 2 places: in the safety section, where it states that the adverse events profile in women 27 to 45 is comparable to that in the younger females, and also in the clinical studies section, where the results are summarized. The efficacy estimates for some endpoints are listed, which are high and statistically significant, and also the fact that there was no statistically significant efficacy for CIN grade 2-3 or adenocarcinoma in situ. And a similar paragraph is included in the Gardasil, in the 9-valent Gardasil 9 label. Now, while quadrivalent vaccine was not licensed for use in persons over 26 in the U.S., it has been by other regulatory agencies, as has bivalent vaccine. And 9-valent vaccine has also been licensed for use over age 26. So in Canada and Australia, all 3 vaccines are approved for use in females aged 9 through 45 years, and quadrivalent 9-valent vaccine are approved for use in males 9 through 26 years. And the European Medicine Agency states that all 3 vaccines are approved for use from the age of 9 years, implying no upper limit. Now, these are regulatory approvals, and as I mentioned, in most countries, I want to mention that in most countries, vaccination programs are limited to early adolescence, and some countries have limited catch-up programs, and many countries don't have a vaccination for males. Now I want to give a very brief overview of the HPV vaccine clinical trial data in mid-adults. has contributed to some of these regulatory approvals in other countries. And as I mentioned, Dr. Luxemburg will provide more data specifically about the information that's included in the application to FDA. 2 efficacy trials have been conducted in mid-adult women, one for quadrivalent vaccine and one for bivalent vaccine. These were multinational studies including women from 7 and 12 countries respectively. Now, today we're addressing the 9-valent vaccine for which the quadrivalent data are most relevant, but I'm showing you data from both trials. The quadrivalent trial, also known as Future 3, enrolled women 24 through 45 years and included over 3,800 women. And the bivalent vaccine, also known as Vivian, enrolled women older than 25 and included over 5,700 women. And the primary endpoints were similar in both trials: vaccine type, 6-month persistent infection, or vaccine type related CIN1 or worse. And the quadrivalent trial endpoint also included external genital lesions. This slide shows the per protocol efficacy results for the 2 trials for 16-18 related persistent infection, CIN, external genital lesions, and for the CIN2 plus outcomes. And the per protocol population, to remind you, includes women who are PCR negative for the respective relevant HPV type and women who received all 3 vaccine doses. For the first endpoint, efficacy was statistically significant and similar in both trials, 84.7% and 90.5%. For 16-18 related CIN2+, the point estimates were very high, but were not statistically significant. As you can see, there were very small numbers. There was only 1 case in the vaccine group and 6 cases in the control group in both trials. There's been no efficacy trial in mid-adult men. A safety immunogenicity study was conducted in men aged 27 to 45. This was an open-label, single-arm trial, and men received 3 doses of the quadrivalent vaccine. Men were recruited from an ongoing natural history study cohort of men in Florida and Mexico, and about 150 men were enrolled. 100% of the men were seropositive to all 4 vaccine types after dose 3, and the antibody titers were more than 10-fold higher than pre-vaccination titers among those who were seropositive at day 1, representing natural infection. So in summary, since the end of 2016, 9-valent vaccine has been the only vaccine available in the United States, and 9-valent vaccine is licensed for use in males and females aged 9 through 26. An application to expand the age indication for 9-valent vaccine through age 45 is being reviewed by FDA. A quadrivalent efficacy trial was conducted in females 24 through 45, showing high and statistically significant efficacy against persistent infection, CIN, and external genital lesions due to the vaccine types. And no trial has been conducted in males or females among persons over age 26 for the 9-valent vaccine, and there's been no quadrivalent efficacy trial among males in this age group. And bridging efficacy and immunogenicity data accepted for other vaccine approvals will inform consideration of the expanded age application. And as it was mentioned earlier, we've just started to review these issues on the ACIP vaccines work group, and I want to thank all the members.
Thank you. Dr. Markowitz, do you want to take questions now or go on to Dr. Luxemburg first? Okay. Dr. Luxemburg.
Good afternoon, everyone, and thanks for the opportunity to speak about our data. It's been a long program for mid-adult women, and without further ado, I think a lot of my introduction has been already covered, in the 2 previous presentations. But to go briefly, we are looking now for an expanded indication. Covering mid-adult men, mid-adult women, age 27 to 45. The FDA has granted priority review, which underlines the importance of this extension. And as a reminder, even though the upper age in the US for the HPV vaccine is 26 years, in a number of other jurisdictions, there is a higher upper age. And as Dr. Markowitz mentioned, the data we will review together about mid-adult women are data with a quadrivalent vaccine. We do not have data this time with a 9-valent vaccine. However, given the importance of the public health issues and the need, and also the fact that the two vaccines are very similar in terms of manufacturing process and also in terms of their immunogenicity and efficacy, the data with the 4-valent vaccine are considered relevant to the 9-valent vaccine. A number of regulatory agencies have agreed with that based on a number of successful bridging studies. So my presentation will have two parts. A presentation about the data in mid-adult person, which is going to be with the 4-valent vaccine, abbreviated as QHPV vaccine, quadrivalent HPV vaccine. And then we'll review a few data supporting the idea that 9-valent and 4-valent are, are very similar. So this is a 10-year study. So the study that was started as Future 3 back in 2004 has been prolonged for 10 years. So we have the privilege to conduct a really important study for a long time. We've been persistent. And you can see that there are two parts. There is a base study which is placebo-controlled. This is a part of the study that's already published and that has been reviewed in the past by ACIP and also by the FDA. And then the study was continued, as a long-term follow-up extension. Only the group that was initially vaccinated with 4-valent was followed. Let me take that back. We followed also the group that received placebo. It was more exploratory because they received vaccination at the end of the base study. And so, we are going to look now at the totality of the data. The three next slides are going to be on the base study. It's just a reminder because these data have been published, they've been presented before. But these are the baseline characteristics of the randomized subject in the base study. So at day 1, you can see the age range. It's certainly between 24 and 45. What I'd like to bring to your attention is that the baseline HPV DNA prevalence was not very high. At least if we look at the vaccine HPV types, you can see it's in the single digits, which underlines that these women are not overwhelmingly infected by HPV. There is some infection, but there is certainly a lot of room for more infection if they get exposed, and so it's a largely susceptible population. These are data in terms of efficacy compared to placebo. So in the base study, we could measure efficacy because we had a control placebo group. And, you can see that the study was mostly powered for 6 months persistent infection at the first row. We have also statistical significance for other endpoints, cervical disease, SIN of any grade, and condyloma. As mentioned, the study was not powered for SIN2. So even though we have a good efficacy and we have a good case split, we didn't reach statistical significance. These data were published again. And this is a brief overview of the safety. You have here a summary of the vaccine-related adverse events. And it is just to say that the safety profile in adult women is consistent with the safety profile that was observed in females of other age groups. Let's go now to the long-term follow-up data. So once again, subjects who were in the placebo group were vaccinated, but a cohort of subjects who received the 4-valent vaccine, the base study, consented to participate for longer term. Long-term extension was in Colombia, which was the largest country in terms of enrollment, and also the investigators were very motivated to continue the study. So these are some of the reasons why we continued in Colombia. The data were, assessed in terms of vaccine effectiveness, using as a measure the cumulative probability of acquiring the primary endpoint, which for the extension was a combined endpoint of cervical disease and condyloma due to the 4 vaccine types, using for the primary analysis the per protocol population of susceptible subjects who were not infected with HPV at baseline and received the 3 doses of vaccine. In all the rest of the presentation, we are going to focus on women 27 to 45. So as you may remember, the overall study was conducted in women 24 to 45 years of age. But since the vaccine is already recommended and licensed up to age 26, we think it's of interest to look specifically at 27 to 45. And the total follow-up is up to 10 years for efficacy with a median of 9 years post-dose 3. So looking back in the base study, focusing on data in 27 to 45 years of age, you can see that, the efficacy was still very high, 95%. This focuses on the endpoints that's used in the long-term follow-up studies, CIN and condyloma. I'd like to say that from now on, all the slides data that I'm going to present have not been presented before. They are presented publicly for the first time to ACIP. These are data now, so the previous slide was in the base study. Now these are data looking up to 10 years. I'm going to spend a little bit of time on this slide. There are a lot of numbers. The data were analyzed by 4 years interval. And the reason is that it facilitates the comparison between the base study, which was approximately 4 years, and then we look at other interval. You can see year 4 to year 8 and year 6 to year 10 for the purpose of comparison. You can see also that in the year day 1 to year 4, which is roughly the base study, we have data for all subjects, and then we look at Colombia and not Colombia because Colombia is followed up later in the base study. To summarize, we have much less cases. Only one case, essentially in the base study for in the Gardasil group, in the 4-valent vaccine group, and a number of cases in the base study, so consistent with what we've seen before. And if we look year 4 to year 10 or year 6 to year 4 to year 8 or year 6 to year 10, there are zero new cases. So at face value, it indicates that, in Colombia, you can see there are 0 cases in the base study, in the Gardasil group, and we still have 0 cases, up to 10 years. So at face value, it speaks to sustained efficacy for 10 years. And, this is the endpoint related to type 6, 11, 16, 18, which are the 4 types in the vaccines. Now, if we look on the next slide at the same endpoint, but for 10 cancer-causing types that are not in the vaccine, so the vaccine doesn't cover for it. So you can see in the base study that we have a number of cases, and roughly they're similar between the placebo group and the 4-valent group. And then if you continue during the long-term follow-up, the subject remain exposed to the non-vaccine types, which means that the fact that we had 0 cases in the long-term follow-up study on the previous slides indicates real effectiveness. We do not have exposure. It's not due to lack of exposure to HPV. It's not due to lack of sexual activity. Women are exposed to non-vaccine types. They are, exposed to HPV essentially, but the effectiveness is maintained. So to summarize, these 10 years of data, we've demonstrated durable effectiveness through 10 years. And, with no case of disease and condyloma, continued exposure to non-vaccine type, and a follow-up through 10 years with a median of 9 years post-dose 3. We've also demonstrated sustained immunogenicity through 10 years post-vaccination onset. For the sake of time, I'm not going to present the data, but they've been presented in the data sets that you have, and they will be publicly posted. And the vaccine was generally well tolerated. We've seen the data for the base study. There were no vaccine-related serious adverse events during the entire study. Now I'm going to present a few more data which are supportive, and they are immunogenicity bridging data. Immunogenicity bridging has been recognized now as an important piece of data that helps and that can even help establish efficacy. So we went back to all the studies that were conducted in young women, adult women, young men, adult men, and try to gain more insight by comparing immunogenicity. So looking here in this study, we look at Future 1 and Future 2, which were the efficacy study of Gardasil in young women, 16-26. We looked at Future 3, the efficacy study in adult women. And likewise, we looked at the study in young men, Protocol 20, compared to the MAM study, the mid-adult men study. It was an external study in adult men. All these data are published, and you have the references here. I'd like to bring. So the idea is to look whether we can demonstrate non-inferiority using the non-inferiority criterion that has been commonly used in the 9-valent vaccine program, which means demonstrated less than 1.5-fold decrease. Population analyzed. I'd like to bring your attention that we used, even though Future 3 was conducted in 24 to 45-year-old women, we used for this analysis 24 to 45, and the women that were 24 to, so we used 27 to 45, and the women 24 to 26 in Future 3 were pooled with the women in Future 2 and Future 1. So these are the non-inferiority analyses for young women, adult women versus young women. And you can see that the GMTs at month 7, 1 month after the last dose, are generally lower in adult women compared to young women, which is known. There is a decrease in immunogenicity with age. However, the lower bound of the 95% confidence interval of the GMT ratio, so the last column, shows that, in all cases it's greater than 0.67, which demonstrate non-inferiority. So at face value, it tells you we have non-inferiority, which means the efficacy results previously established in young women could be extended to adult women. And that's true especially for the endpoint of SIN2, for instance. We conducted the same analysis for men, and here you can see also that we have a generally lower immunogenicity. It's not true for type 16, though, interestingly. So in adult men compared to young men, GMT ratios are also showed here, and we pass the non-inferiority criterion for type 6, 11, and 16. For type 18, we are a little bit below for the lower bound, 0.61 instead of 0.67. Want to bring your attention to two facts. One, it's a small number of subjects, and it's very likely that with a bigger number of subjects, we would have a narrower confidence interval. Also, I'd like to bring to your attention that, the main types causing disease in men are 6 and 16. So, overall it's encouraging, and it allows to infer efficacy in adult men. I have a few slides here just to remind you these are data that are published and data that also have been presented to the ACIP, supporting similarity between the two vaccines. And, once again, we've had consistent success in bridging between the two vaccines, consistent safety profile as well. And so, if we look at, again, immunogenicity bridging, comparison of immunogenicity, these graphs compare immunogenicity at month 7 in 3 demographic groups. So we are looking at young women, girls, adolescent girls, and young men. And uniformly, we can see that the GMTs are very similar. And formally, we pass non-inferiority for all groups, which shows that regardless of gender, regardless of age, the two vaccines tend to perform the same. And this is at month 7, but if you look over time, these data were recently published. This is in young women. The two vaccines continue to perform the same, at least through 3 years post-vaccination. 9-valent vaccine being in green, blue, and 4-valent vaccine between in orange. And finally, also some slides to show that efficacy is very similar for both. This slide combines both the 9-valent, the 4-valent vaccine program. You can see that in the 9-valent vaccine efficacy study, the case of disease, looking at cervical, vulvar, vaginal warts, due to the 4 types, due to the vaccine, are very low, and in the backup slide, you can see that the statistical analysis shows no significant difference between the two groups. And to put it in perspective, if you want to compare these numbers to a non-vaccinated group, so the historic placebo group of the 4-valent vaccine program, we see that there is certainly a lot of decrease. But this slide is, once again, to remind that the two vaccines perform the same, both in terms of immunogenicity and in terms of efficacy. And so in conclusion, my final slides, we've here demonstrated 10 years efficacy effectiveness, in adult women for the endpoint of SIN and condyloma. The immunogenicity data demonstrate non-inferior immunogenicity in young population, young men or young women population where efficacy was established, compared to adult men, adult women, which further supports efficacy. The safety, the 4-valent vaccine was generally well tolerated in adult women. And you have in the backup slide also safety data for adult men. And once again, the data are relevant to the 9-valent vaccine due to the clinical experience and the manufacturing. And I'd like to disclose also, and it's obviously public information, that we are conducting presently an immunogenicity study of the 9-valent vaccine in adult women. It's a post-marketing study that was requested by the European Medicines Agency. As a reminder, the EMA licensed the 9-valent vaccine in adult men, adult women, from age 9. So it's really a post-licensure study. So they licensed it 3 years ago. We are conducting that study, and it's to demonstrate non-inferiority. And we expect analysis in second quarter next year. Thank you for your attention.
Thank you very much. Can we take questions now for both speakers? Dr. Hunter.
I'm not sure there is an answer to this question, but I'll ask it anyway. Is there any data to suggest what the biological mechanism of the efficacy of HPV vaccine is in decreasing cervical epithelial neoplasia rates in women aged 27 through 45 years old, especially whether it's due to preventing infection from HPV strains they haven't been exposed to already versus preventing progress from an initial infection to chronic infection and then on to neoplasia?
Yeah, there are a lot of questions here. So I'll and it's a very good question. There are now new data, and from the long-term follow-up clinical studies, both of the bivalent vaccine and the 4-valent vaccine, that new infection during the study, new persistent infection during the study is followed by emergence of cervical disease and high-grade cervical disease. These data are published, and interestingly, the rate of progression is similar to what was seen in young women. So these are very useful data because they show that during the study, in a very controlled environment, and this study were 7 years or more, we can observe the natural history, and it's very similar. So certainly there is grounds to say that the mechanism of protection is the same. You know, these women continue to be exposed, especially with new sexual partners, and they continue to develop disease in a way that, as far as we can judge, are indistinguishable from young women. Now to the second part of your question, which is could this part of it be also pre-existing infections that are reawakened and maybe the vaccine helps? It's difficult, as you said, to answer the question because it's difficult to distinguish exactly what would be, you know, the concept of latent infection, which is talked about a lot, but with very few data, or re-emerging infection. What we can say, though, is, you know, after 10 years of follow-up, we didn't see any evidence of, you know, infections that are re-emerging, you know, that were hidden, you know. So that's, you know, it's a possibility, but it's low likelihood. I mean, certainly there is a lot of benefit for protection against new infection.
I have one question. In your long-term follow-up studies, I couldn't quite figure out the numbers, but was there a significant loss to follow-up?
Yeah, that's a good question. The number of, you know, I'd like to go back, you know, with the work group to the exact numbers, but I think we kept most of the Colombian women, you know, I think it was probably at least 75 or 80% of the initial enrollment in the long-term follow-up. And, the attrition was similar to what we've seen in other studies. Typically what we see is, you know, something around 4 to 5% attrition per year.
Yes, Dr. Riley.
This may be for Dr. Markowitz, but is there a plan to have a cost analysis of what this would look like? Okay.
Other questions? Dr. Lee.
And you probably don't have the power for this, but were you able to take a look at the biotype-specific disease and get a sense of any differences at all in efficacy rates?
I mean, in the base study, yes, I think there was analysis by type. In the long-term follow-up, you know, I mean, zero case is zero case of all of them.
And then the distribution of vaccines, sort of the HPV types in the 25 to 49, what proportion of women will potentially benefit?
I mean, you know, what I briefly showed the prevalence of HPV at baseline, and there was infection for all 4 types. You know, I think, if I remember correctly, 6 and 16 were a little bit higher than the other, which is very usual, I think.
Thank you very much. Dr. Markowitz?
Okay, so in this last talk of the session, I'm going to review some general considerations and the ACIP HPV vaccine workgroup plans. And again, we've just started to consider this as we were just recently made aware. So I'm going to be talking kind of as in general terms, and we're hopefully, we will in October, have a lot more data and specific plans to share with the committee. And so I'm going to talk about an introduction to policy considerations, give a kind of a high-level overview of evidence that would help assess the burden and benefit in this population, in this age group, talking about HPV epidemiology and some general concepts that would be important to think about. Also present the range of policy options that be considered, and then plans for the October meeting. Now, in considering policy of an extended age indication, it's important to emphasize that these available vaccines are prophylactic. And I want to just highlight and answer your question that these will prevent new infections. And there's plenty of data from the vaccine trials showing that if someone's infected at the time of vaccination, in the efficacy trials, vaccination did not prevent progression to a precancer lesion, and it didn't enhance clearance. So it's actually not going to help people who are already infected. And so these vaccines are prophylactic, and although there's some different evidence coming out, that's still our basic understanding of these vaccines. So therefore, the vaccination will have greatest impact and is most cost-effective when administered before onset of sexual activity and exposure. And we know that over 90% of men and women are sexually active before their mid-20s. And of course, models show, and there's been a lot of models done for HPV vaccine, that cost-effectiveness of vaccination becomes much less favorable as age at vaccination increases. And just to give you an idea of what this looks like, I want to show you this figure from some modeling done at the very beginning of our program when we had a female-only vaccination program. And it shows the incremental cost-effectiveness of including older age groups in the vaccination program as well as different health outcomes. And the main point of showing this is to show that the cost per quality increases quite dramatically with inclusion of older age groups, and it also shows that it's more favorable as you include more health outcomes. But the main reason I'm showing you this is the effective age group, and we are going to be updating our modeling. A lot of work has been done on models since the beginning of vaccine introduction. And this is obvious, but I want to point out that the expanded age indication will not impact our routine vaccination program in the U.S. We recommend vaccination 11 to 12. Of course, it could impact our catch-up recommendations and also impact recommendations for people who are older than whatever the determined catch-up age is going to be. And that's what we really need to talk about and determine the benefit of vaccination beyond the current catch-up age of 26. The work will be using the evidence to recommendations framework, and the elements of this are shown on the right slide. And we've started reviewing some of the evidence for this, and today what I'd like to do is give an overview of some of the data needed to define the burden of disease, so we can kind of define the problem and the potential benefit of vaccination in this age group. I think most of you know the burden of disease due to HPV includes outcomes that are associated with oncogenic or high-risk types. There are 13 to 14 types, 16, 18 being the most important. And these outcomes include a variety of anogenital cancers and oropharynx cancer and intraepithelial neoplasias that are picked up with cervical cancer screening. And the outcomes due to non-oncogenic types, mainly 6 and 11, are anogenital warts and recurrent respiratory papillomatosis. This slide shows the estimated number of cancers that are attributable to HPV per year in the United States from 2010 to 14. And an attributable cancer is a cancer probably caused by HPV. And we've estimated this from 2010 to 14 that HPV has caused about 32,500 cancers per year in the United States, about 19,700 in women and 12,800 in men. And most of these cancers in women were cervical cancers, and most of the cancers in men were oropharynx cancers. And at the last ACIP meeting, we heard a talk on the trends in HPV-associated cancers, and HPV-associated cancers attributable to HPV at the oropharynx are increasing in the United States, particularly in men. Overall, about 92% of these cancers could be prevented by the 9-valent vaccine. Now, the benefit of vaccination at different ages depends on preventing infections that lead to these cancers and precancers, which occur years or decades before the cancers occur. So the benefit and potential impact of vaccination is influenced by many things: the likelihood of already having had a vaccine-type infection, the risk of incident infection, and then the risk of development of disease from that incident infection. And there's also a lot of questions about immunity after natural infection, if you can get reinfected with the same type, and vaccine efficacy against that reinfection. I think everyone knows HPV is a very common sexually transmitted infection in males and females. And while much is known about the epidemiology, there's still many unknowns. And there's been increasing understanding with regard to differences by sex. prevalence and infection rates may differ by sex, and patterns may also differ by anatomic site of infection. For example, prevalence at the genital site is higher than the oral site, and immune responses differ by anatomic site of infection. And response to natural infection is stronger and appears to be more protective against reinfection in females than males. And some of these, again, are unknowns, and these are just some preliminary data on some of these things. Now, to give you an understanding of some epidemiology in the U.S., I'm showing you data here from a national representative survey, NHANES, and this is showing any HPV prevalence in self-collected cervical vaginal swabs in females and penile swabs in males. And any HPV here includes any 37 types that are measured by one of the widely used PCR assays. And these data here include our first national data in males. Prevalence is high in males and females, but you can see that there are some differences by age. As in many other studies in females, these data show that prevalence peaks in the late teens, early 20s, and then is lower in older age groups. In males, prevalence is similar in the age groups age 25 to 29 and older. Now, these differences by sex may be due to differences in incidence of new infection, in clearance of infection, or both, or they could be due to cohort effects because this is a cross-sectional study. And if they're due to new infections, they could be due to differences in sexual behavior or immunity after infection. And it's important to note that infection in younger age groups are most likely due to new infection, while infection in older age groups are more likely to be due to a persistent infection. Now, there's many sexual behavior surveys and behavioral surveys in the United States that show the percentage of persons with a new sex partner decreases with increasing age after age 20 for men and women. And on this graph, I'm showing you data from NHANES, the same survey. And while higher for males than females, the percent with at least one new sexual partner in the past year was successively lower in both age groups for females and males. In spite of this, you can see the prevalence in males was fairly similar in the older age groups. Now, consistent with the data from prevalence studies, prospective data show that among women, the risk of incident infection decreases with increasing age. And this is a study from Columbia looking at incidence among 15 to 85-year-olds, and you can see that there was a decrease in incidence by age. The lines on the graph are the different age groups, and the y-axis is cumulative incidence. While there were incident infections in all age groups, the highest cumulative risk of infection was in 15 to 19-year-olds, and incidence decreased with age and was lowest in women over 45. Now, much of the data we have from HPV in men actually comes from one major study, which is a cohort study conducted in the US, Mexico, and Brazil called the HIM study. And this slide shows data from that study of HPV incidence among 18 to 17-year-old men who are followed for 36 months. And you can see the cumulative risk of infection was somewhat more similar across all age groups, although lower in the oldest age group. And in this study, the number of new sex partner was also similar in all age groups, which could account for these findings. And the findings in the male and the female studies I just showed you cannot be directly compared, but they do provide some insight into the different patterns of HPV infection among females and males, and certainly show that males are at ongoing risk for new HPV detection. Now, complicating interpretation of these incidence studies is that an incident infection in an adult may be due to a newly acquired infection or to redetection of a previously acquired infection. And a redetection could be the result of a persistent infection that is intermittently below the level of detection of the PCR assay, or it could be due to reactivation of a latent infection. And these are very difficult to methodologically to distinguish. And the relative proportion of new to redetection could impact the potential benefit of vaccination in the older age groups because vaccination is expected to prevent new infections. Now, several studies have been conducted in females to try to estimate the proportion of new detections that are due to new infections by evaluating risk factors for a new HPV detection. And I'm going to review two of these studies here. These studies are both U.S. studies, and they provide information on incident HPV detection in mid-adult women, and they also try to estimate the proportion of a new detection that is due to a new infection. These studies looked at HPV detection and sexual behavior and used that to determine attributable risk to new and past exposures. You can see that the characteristics were quite different in these two studies. For the first study listed, women were enrolled from multiple U.S. studies and were online daters, aged 25 to 65, and 50% had a recent new sexual partner. And the study in Baltimore included, and the risk in this study was 29.5 per 100 person years. The study in Baltimore was a lower risk population recruited from OBGYN clinics, and only 10% had a recent sexual partner. And the incident detection was 14 per 100 woman years. And I want to note here that this was any HPV, not high-risk HPV, so the rate would even be lower. In both studies, most of the detections were attributed to past, not new acquisition. Both based on the association between new detection and sexual risk behavior, it was estimated that among women with new partners, though, 62 to 80% of the new detections were in fact attributable to a newly acquired HPV infection. Now, a study in Seattle included serology and enrollment to characterize persons with potential past infection. And in this study, incident detection varied by serostatus, and it actually was higher in those who were seropositive at baseline. However, an association between recent sexual behavior and incident DNA detection to that same type was only found among seronegative women, those without serologic evidence of exposure. This suggests that among seropositive women, redetection of the same type was more likely to be due to reactivation or intermittent detection of a persisting infection rather than a new infection. So to summarize briefly, the risk of incident infection declines with increasing age for females, likely due to more stable partnerships and fewer new sex partners, could also be due to some acquired immunity. And sex with a new partner remains a risk factor for a new infection in older age groups. And the proportion of new detectable HPV due to a prior versus a new infection varies by population and depends on both past risk behavior and current risk exposure. Now, given that we know that new infections do occur in this age group, it's important to address the question, what is the risk of these new infections developing into a precancer lesion? And as mentioned earlier briefly by Dr. Luxemburg, data to address this are available from the control arms of the vaccine trials. There's some good data from the bivalent trial showing that over 48 months, about 3.6% of the new infections did progress to a CIN2+ lesion. Now, we know a lot less about males than females. It appears that among males, the risk of incident infection is more constant with increasing age, and the risk of an incident infection is a risk factor for a new infection. Redetection, I haven't shown you this data, but redetection of the same type is common, and it's really a lot less clear what proportion is due to a new detectable, what proportion of that is due to a prior versus a new infection. Now, type-specific immunity after natural infection could explain some of the differences observed by sex in prevalence and incidence, and it's also a very important question for consideration of the benefit of vaccination. There's little immunity after natural infection. Benefit of vaccination would be greater than if natural immunity provides complete protection, and in fact, models have shown this to be a very important parameter in the modeling work. And this slide shows results from a systematic review and meta-analysis that was conducted to address this question. Over 24,000 individuals were included from longitudinal studies addressing this question by looking at serology and comparing the risk of genital infection by seropositivity status. There were 14 studies, 11 in females at the top of the forest plot and 3 in males. And this figure shows the results for HPV 16, and results did vary by HPV type. But the conclusion was that antibodies acquired through natural infection provide some type-specific protection against subsequent genital infection in females, but not males. And data from the control arms of the efficacy trials from females do support this assumption that there is modest protection from from reinfection among females from natural infection. Now, modeling has provided some very important information for HPV policy due to the very complex nature of HPV and many unknowns and the many different outcomes. And this slide shows results from a study that was published late last year that used a well-documented cervical cancer natural history disease simulation model based on U.S. data and tried to address the question, what proportion of cervical cancers are caused by infections acquired at different ages? And this was under the assumption of the absence of screening or vaccination. The model projected that among all cervical cancers, 50% of women acquired their causal HPV infection by age 21 and 75% by age 31. This, of course, strongly supports routine vaccination at a young age to prevent most infections that lead to cancer, but also provides information on projected infections acquired at older ages that might result in a cancer. It's important to note that this model projected cancers in the absence of screening and vaccination, and the percentages would appear different in the context of our current program. Now, in contrast to cervical cancer, much less is known about the natural history of some other HPV-associated cancers. And this slide is from a presentation from the February meeting when the epidemiology among males with particular reference to oropharynx cancer was discussed. And Dr. Chaturvedi from NCI highlighted the very few natural history studies to look at the steps between oral acquisition and the development of HPV-positive oropharynx cancer, the cancer that happens to be increasing in the United States related to HPV. Among the other unknowns for this, shown on the right side of the slide, are the time between acquisition and development of cancer and the disease relevance of infections at an older age. And of course, the lack of information about natural history prevents us to project any estimates of similar to what was done for cervical cancer on the previous slide. Now, in this talk, I've mainly been addressing genital infection, and we know that the epidemiology at other anatomic sites differs. Also, we know the prevalence of HPV and HPV-associated disease is higher in some populations. Anal prevalence is higher in men who have sex with men, and anal cancer is particularly high in men who have sex with men who have HIV infection. And there's a very large and increasing literature on this topic. And women who have HIV/AIDS have significantly higher rates of cervical cancer and some other HPV-associated cancers in the general population of women. And the work group will consider special populations, including immunocompromised persons and MSM, at a later meeting. So in summary of this part of the talk, based on epidemiology of HPV, the population-level benefit of vaccination of mid-adults would be low compared to vaccination at younger ages. In general, new sex partners decrease with increasing age, but sex with a new partner remains a risk for new HPV infection at older ages. There are differences by sex in prevalence, incidence, and immunity after infection, and also in the outcomes of HPV, HPV-associated cancers. Immunity after natural infection is an important determinant of potential impact of vaccination. This might differ between males and females. And updated modeling and cost-effectiveness analysis will be very helpful due to the complex nature of HPV and HPV natural history. Now, the work group is continuing to review data to inform the burden of disease and infection in older age groups, and this, of course, will affect our policy considerations. But on this slide, I'm really showing the range of policy options that could be considered. So for catch-up, we could, one option is to retain the current catch-up age of 26. We could decide to extend the catch-up through an older age group. And then for persons who are older than the determined catch-up age group, whatever that is decided upon, there could be no recommendation for vaccination at older ages. There could be vaccination recommended for individual decision-making. And there could also, and these are not mutually exclusive, be recommendations for specific groups and special populations. As Dr. Szilagyi mentioned earlier, the work group has been considering harmonization of the upper age recommendation for males and females through age 26, and there is strong support on the work group for harmonization. Among other evidence reviewed was a survey of the Association of Immunization Managers and of primary care physicians. This indicated that over 90% supported harmonization. And this will be considered as the work group moves forward to review data related to the possible expanded age indication. Our work group plans in June. This meeting, we have just really introduced this topic, provided some background on the application. You heard the clinical data submitted in the application for the extended age indication. And I just discussed some general considerations, some issues trying to define the burden in this age group and work group plans. In October, we plan to review further the epidemiology and burden of disease. We hope to have our modeling and cost effectiveness completed. We will also be reviewing values acceptability and other elements of the evidence to recommendations framework and have more specific policy options that the work group is considering. And I'd like to again thank the work group, which has shifted gears and been tackling this new issue in the last very few months. And I want to acknowledge Harold Chesson and members of my HPV team for helping review this presentation. So we are planning on presenting a lot more data, but I did want to end with some specific questions about, are there specific data the ACIP would like presented? And also, are there specific options or other considerations on this topic that the work group should address?
Thank you, Dr. Markowitz. That was a great presentation. Questions? Yes.
Carol Hayes with the American College of Nurse Midwives. I would be really curious about the insurance payer and rates on the high-risk HPV. And I know that on that slide where you were looking at the incidence of and you had major U.S. cities, Baltimore and Seattle. Do you happen to remember if any of those three studies looked at who the payer was, what kind of insurance the patient had?
This study here?
Yeah. Yes. Uh-huh.
I don't remember, but what do you mean?
Well, when you're looking at the risk of new partner there, the variation is huge. And so I'm curious what economic background, what socioeconomic groups did they fall into? And is that part of the variation?
I think the variation really is that in the first study, this was conducted in multiple studies and they were recruited from online dating sites. And I think really they were a higher risk population, where in Baltimore, these were people coming in for routine cervical cancer screening and other health care at OBGYN clinics. So
what's the percent of Medicaid is my question.
I'm sorry, what?
What's the percent of Medicaid?
Oh, that I don't know.
Right, that's my question.
Yeah, okay.
Yeah.
Dr. Lee?
Thank you for answering my earlier question. That was such a great presentation of trying to get a handle on the burden of disease that we could prevent. The question I have is really around, will you have any information about thinking about coverage for a risk-based strategy versus more of a global catch-up strategy? And could you take a closer look at the risk-based strategy that you have, for example, for the subgroups of men who are in that category to give us a sense of how much coverage we would attain?
We do have some data on coverage in MSM. We could present, hopefully we'll have maybe a bit more of that by October. We know that there's a lot of MSM who haven't been vaccinated. We do know that, yeah. So I think that as we get more into it, we will specifically look at some of those issues about a blanket catch-up extension versus focusing on specific groups. But
Just to comment on that, it could be really helpful in considering this to think about some of the special risk groups that might be vaccinated to a higher age and sort of do an incremental analysis of comparing that to a age-based strategy. Mm-hmm. Because sometimes we forget that there's a whole bunch of people in the age-based strategy that are going to get vaccinated anyway because of their other risks. Other questions? Yes, Dr. Riley.
This is less of a question, more of a comment, because I'm not going to get to comment in the future. I just think as a practicing OB mostly, not doing that much GYN, I do think that we have to take into consideration the other practice things that are changing for which more protection may be important. So one thing is, obviously, behaviors are changing. So just looking at the online daters, I mean, I think sometimes we get ourselves into the thought that it's only the young, and it's not. It's everyone. And so we just need to think about the fact that risk behaviors may be different than what they were 10 years ago. So I just mentioned that. And then the second thing is sort of our reduction in pap smears, sort of spacing them out to 3 years, 5 years, that's going to create a different level of risk as well within the same community. And I just think that we need to think about that as we're thinking about the context, not just the cost, obviously, but the context in which this might be more useful to the population.
Thank you. Dr. Fry.
You may already have this data. Would you be able to present some information on sex workers?
Actually, we don't have data on sex workers in the U.S. It's an interesting question, but we can look and see if we can get some data on that. Yeah.
Ms. Pellegrini.
I'm going to follow Laura's model here and make a comment since I won't be able to either in the future. Just as it will be very interesting to track over time what happens in the teen population. I'm really struck by this figure that 50% of the causal infection is happening by age 21, because what studies are showing is that teenagers are increasingly postponing sexual activity. So if we continue vaccinating in these teen years, we may actually have higher effectiveness in the future if that trend continues, which of course would be fantastic.
Thank you. Dr. Moore.
Just a quick comment. As the work group considers what to do about the middle-aged adults, of which I just stepped out of the range, unfortunately, apparently, according to this, one thing to think about for individual clinical decision-making, we have such a hard time programmatically with any kind of risk-based recommendation. Another way but I can understand and appreciate why that would be a valid consideration. Another way to think about it is to maybe think about a lack of risk opt-out consideration as opposed to so in other words, an intermediate step to say it should be given unless certain circumstances, then maybe you could consider not giving it under these circumstances, as opposed to only consider it if they have risks. It's more like if they have characteristics that put them not at risk, then you could consider bypassing the vaccine. So maybe a way to think about it that might make it easier programmatically to implement.
Mm-hmm. Dr. Fry.
I worry about that risk opt-out for teenagers. Oh, no. But you're talking about
I'm talking about middle-aged adult women,
specifically.
Men or women who are, yes, in that middle age.
Yeah. I mean, we're talking about 30, 35-year-old who's coming in, and what strategy you would have for that particular person.
Other questions or comments? Oh, Dr. Sun.
I have a question on your point that you made about the difference in immunity in males and females. You said that on your slide 20, the systematic analysis that the protection from natural infection doesn't appear to be as strong in males as in females. Is that a function of the serotype of infection, or is it something about males? Because wouldn't that, if that were true, wouldn't that mean that males will be less likely to benefit from vaccination if they don't develop immunity from exposure?
This is from natural infection, and I think that part of it, and there's been a lot of studies that after natural infection, a much smaller percentage of males will develop antibody than females. That's one thing. a very, very small percent. We know that among females, it varies by type, but maybe 60% will develop an antibody response after a natural infection. In men, it's probably less than 20. So part of it's due to the site of infection is it mucosal or keratinized tissue that they get exposed at. So that's one thing. So, but in general, there's been some work to suggest that the antibody developed after natural infection in males is less protective. Not vaccination. In vaccination, we know that males have efficacy in males in the trial has been very high. Because it's really from the natural infection and the site of exposure. It differs.
Dr. Middleman?
Amy Middleman from SAM, Society for Adolescent Health and Medicine. I just want to put out there that SAM is really encouraging and hopeful that there'll be harmonization sooner rather than later for males and females. I didn't get a sense from the presentation, and I've been in the work group meetings, that much data would change whether or not we would specifically want males to have the same recommendation as females up through age 26. And we're just hopeful. We've been waiting a long time for this, hoping to really catch up those males with the same fervor that we do with females up through age 26 and protecting as many people as possible. So we'd really love to see harmonization as soon as possible. And I'm just curious to know if there's anything that is out there that is preventing that from the data that we've seen thus far, or what data would we see in the future that would change the idea of harmonization?
You're always going to look at me and make me answer that question. We certainly appreciate the enthusiasm for harmonization, and we share the goal of simplifying recommendations. We have certainly learned with HPV as well as with other vaccines the value of not making too many changes at the same time or sequentially over the year, because recommendations aren't just about what you all do at this meeting, but it leads us to a need to have a communication campaign with our partner organizations to communicate those changes to providers. And so we highly value the harmonization, and we look forward to having a single discussion with a single recommendation that both considers a harmonization, but also considers at what age group that harmonization would be to, so that we can actually communicate as in one fell swoop, as opposed to trying to do it sequentially.
Okay. Any further comments, questions? Okay. Seeing none, I think we'll move on to the next session. Dr. Schaffer is going to introduce the session on NITAGs.
Hello, everybody. Thank you. I'm just going to give a couple minutes introduction on CDC work in the area of NITAGs. And then Dr. Hombach from the Secretary of SAGE is going to talk more about global NITAG activities and the global NITAG network. So CDC has played a role in NITAG strengthening for over 10 years. And the main group at CDC who works in the global NITAG strengthening is the Global Immunization Division, which is where I'm from. So we provide technical assistance in the form of developing training materials and tools. We help facilitate trainings. We work with we work with WHO, of course, and we also work with the disease-specific initiatives such as PIVI, Partnership for Influenza Vaccine Introduction, and RAVEN, Rotavirus Accelerated Vaccine Introduction Network. And that's mostly working with working groups that are NITAGs that are planning on introducing those vaccines. We also do research, and there are a couple projects we're doing now looking at how NITAGs integrate into the policy process in different country contexts, and also how NITAGs kind of link with other expert advisory groups in countries like national verification committees for measles, rubella, and also certification committees for polio. We also provide funding to WHO headquarters to support NITAGs traveling to SAGE meetings, NITAGs traveling to regional TAG meetings, to support regional trainings, and to support the NITAG Resource Center, which is going to be discussed a little bit more later. And of course, GAD also collaborates very closely with NCIRD on visits to ACIP and on a number of other activities and trainings. And these next two slides are just showing the trainings that CDC has been involved in with partners, with WHO and partners, since 2009. And we've really worked in kind of over 600 with over 60 countries in all the regions, WHO regions. Some of these have been countries just for trainings for one country. Some have been multiple countries, and some have been regional trainings. And some have actually involved bringing NITAG members to ACIP meetings and having further training here. And this just shows the extent of kind of our involvement in these NITAG trainings. And I just wanted to highlight one recent training that WHO and CDC was involved in. This was China's National Immunization Advisory Committee, which was recently established, maybe reestablished in October 2017. It has 19 working groups, 27 voting members, 160 work group members. And there was a training in December of 2017 on evidence-based decision-making, which is more of a experience sharing, not so much didactic. And technical assistants and faculty were supported by CDC and WHO. There were over 200 participants. And following this training, this newly formed NITAG held a meeting and made some recommendations. And I just wanted to share, this is the faculty from the meeting. You might notice some people here, Dr. Rodwald, Walt Ornstein, Amanda Kahn, Lori Markowitz, Cynthia Whitney, and some people from WHO headquarters also. So it was a very collaborative, I think it was a very successful training. And then just my last slide is a tool that CDC is developing with partners and WHO, and it's a simple tool for NITAGs to use to look at their functionality, their quality of work, and their outputs, the recommendations, and their integration into the policy process. It can either be done as a self-assessment by the NITAG or an external assessment. And I know ACIP recently underwent an evaluation or an assessment using a longer tool. So we're pilot testing this now, and we hope it'll be a simple enough tool that can be used as part of an EPI review or a Gavi joint assessment, joint appraisal. So this is something that's going to be pilot tested over the next 6 months. And now I want to introduce Dr. Joachim Hombach, who is the secretary of SAGE, and he's going to be talking about global NITAG activities and the global NITAG network.
Sorry, Dr. Bennett, perhaps for the uninitiated among us, could someone give a brief description of exactly what a NITAG is and what it does?
And we apologize.
That's okay.
Dr. Sheffer, would you like to answer that?
I think Joachim is going to be talking about NITAGs and where they fit into the global vaccine action and what they are.
Okay.
But it stands for National Immunization Technical Advisory Group.
I understand. That's just not a particularly meaningful
And I
name.
apologize.
Good afternoon, and Abby, thanks very much for the kind introduction. It's a pleasure to be here. Thanks for the invitation here to speak at ACIP. So what I will be doing over the next couple of minutes is really to explain a little bit what we are doing, obviously with partners like CDC, in order to support country-level decision-making on vaccines, the National Immunization Technical Advisory Groups, and also how this connects to the work that we are doing at the global level, following the rationale that global-level policy work is only as good as it shows impact in countries. So let me just check. Okay. So let me start very quickly at the global level, and just to point out that at WHO we're actually working along a continuum of, so to say, the vaccine value chain. At the center is really the SAGE, the Strategic Advisory Group of Experts, which is our top-level advisory group on immunization policy and strategy,
but it connects to work that we are doing more upstream, as well as a lot of work that we are doing more downstream. What is important, I think, in relation to the vaccine recommendations that WHO through SAGE issues, is that they have a bit of a lever. And to the extent that, for instance, the pre-qualification of vaccines is only possible once WHO has made a recommendation on the use of a vaccine. Only then manufacturers can submit for WHO pre-qualification, and only pre-qualified vaccines actually can be procured through UNICEF, and then eventually can also benefit from Gavi support. So we have a nice situation here of, let's say, coherence of policy, which of course provides further impact to the recommendations that SAGE makes. That's the advisory group. I'm not going to go through in details. There's quite some resemblance with what is going on here in this room, but there's also quite substantive differences. Obviously, it's a committee that reports to the Director General of the World Health Organization, and has working procedures and so forth. Everything you find on the website on this committee. As here, the bulk of the work is actually happening in working groups. There are time-limited groups that really work on proposing recommendations on very specific issues then for deliberation at the SAGE plenary meeting. What is important to note is that SAGE's scope is relatively broad, so we are doing much more than vaccine-specific recommendations. We recently went through our last 8 years or so of work, and you see that around only 40% are vaccine-specific. There's a lot of reports that relate to progress on elimination, eradication strategies, adjustments to strategy, and so forth and so forth. So it's important to keep this in mind. What is shown here is that we actually, in the way we have set up our work, are really trying to connect to country-level work. So we obviously have the global-level work. And we have, over the last years, established in all 6 WHO regions, regional technical advisory groups on immunization that essentially have the role of course, refining monitoring strategies in the regions, have much closer contact to the countries, and really identify and follow up on their priorities. And then obviously we have the national advisory groups. Now they are of course not WHO, they are national advisory groups. They are part or connected to the Ministry of Health that should be tasked to really prioritize and recommend the use of the vaccine in the respective countries. The role of these NITAGs was actually recognized to be of a very high priority, and we are operating right now in vaccination under the so-called Global Vaccine Action Plan, which started 2011. It comes to the end 2020, so we are all busy thinking about what comes thereafter. And within this action plan was one indicator, which was the presence of an independent technical advisory group that meets a number of process indicators, process criteria, hopefully in all countries by 2020. And these indicators in good company will probably fail to get there, as with many others. But nevertheless, I think there is very good progress in this area. And let me also say, of course, these are process indicators. Meeting these process indicators doesn't necessarily mean that the committee is extremely performing, but at least it's a start and something important. It's also mirrored, the importance of these NITAGs is also mirrored by various resolutions and reviews that are being done on the Vaccine Action Plan. You see here some quotes from the World Health Assembly in 2017 and 2018, clearly charging member states, charging also our organization really to work towards the establishment and the functionality of these committees, as they are absolutely essential for ownership and credibility in countries and sustainability of the decisions that are being taken. That's where we are pretty much today. This is from the last assessment report, so there's a new one coming out pretty soon. You see that we have 2016, we had 83 countries that reported NITAGs to respond to these 6 process indicators. That is more than the double than what we had in the beginning in 2010 when the counting started, which was taken as the baseline. There's in particular, I think, good progress in the African region, even though I think if you look more closely, you see that there have been a little bit of leveling off in the last couple of years. So I think there is progress, but more needs to be done, as with so many indicators. All right. So what are we doing specifically? And to some extent, Abby already referred to some of this work in her brief presentation. So at the global level, there's a couple of elements where we try to focus on in order to really to support the NITAG activities. We need to be fairly selective, and we're trying to provide global resources. And when I say we, it's really very much with partners. There is a NITAG Resource Center, which I will talk about in a minute, which really tries to provide information for all NITAGs. There is the development of guidelines and training materials. There's an effort to allow for networking and collaboration, mostly through the global NITAG network. And then there is some specific support to regional offices. And we're trying also to raise visibility and funding that would go into these activities. At the regional level, our idea is that it is very important that at regional level there are regional NITAG networks that really work together, that exchange information, that we may come to some type of centers of excellence in regions to support NITAG activities. This is, I really have to say, work in progress. We have a network in the Southeast Asian regions. I think we have potentials in other regions, but more clearly work needs to be done. And there's also the idea of having sub-regional collaboration, particularly between small countries where it's virtually impossible to have really functional NITAGs, have all the competency in the countries to do decision-making. So in the Caribbean, there has been such a network. There is plans, for instance, in the Pacific region among small islands to have this type of collaboration. And then we have, at the country level, obviously ad hoc support to NITAG establishment, strengthening, sharing of work plans, peer-to-peer learning, and of course, the execution of NITAG evaluations. The resource center is really, the idea is to have a web-based interface where pretty much all of the information that NITAGs need can be found in relation, first of all, to materials in terms of good practices, but then also technical materials, systematic reviews, scientific publications, and also information from NITAGs and any upcoming events. The target audience is really the NITAGs. And this is something which I think has an enormous potential for growth. It's not just something for lower-income countries. Also, middle and high-income countries have come to us and have said, why aren't we sharing certain pieces of information, systematic reviews, and so forth? There needs to be, of course, country adaptation, but these can be very valuable materials and analysis that can be shared among NITAGs. I think this is clearly an area that needs further development, but it is, if you do it right, resources intense. And then we have, obviously, the Global NITAG Network, and this was launched, I think, something like 2 years ago. I think in 2016 there was a plan to launch this network. It was then officially established in Berlin last year. You see here the terms of reference or the mission, vision of this group. It's really a voluntary gathering of NITAGs. I think we have today something like 40, 45, 47 NITAGs that are in this group, and it's really about getting together, sharing information, and also doing advocacy in this important area. So this is again another important element in order to do really to have peer learning and to exchange information among national immunization technical advisory groups. The next meeting is going to be in Canada. We're very happy that it's going to be hosted there, and in December. And you see here already things that have been put onto the agenda, such as off-label recommendations for vaccination, the legal context for the implementation of NITAG recommendations, conflict of interest, and a couple of other issues. Key messages, I think, from my brief talk here is, I personally think, coming from an organization that not only deals with immunization, but really with a very broad area of public health measures, I think that immunization is leading the field in relation to evidence-based decision-making in public health. And I think this is terrific, and I think we really need to keep this leadership position. As I said before, for us, global normative guidance only is really of relevance if we can make it happen at the country level. And therefore, for us, this collaboration from a global, regional, country level, the involvement of various partners and stakeholders is absolutely essential. I think we can see that we have progress on the agenda of establishing NITAGs. I personally think that NITAGs in the future in low and middle income countries will become much more important. And the reasons are, first of all, as you see at every meeting, vaccine decision-making policy choices are becoming more complex. And this is in all countries. It's really getting very complicated. And the other thing is that we have more and more countries that will be graduating from, for instance, Gavi support. Countries will have to pick up pretty much to the totality the bill for the vaccines they will recommend. So they need to have very good justification, need to go through a very thorough review, eventually also through prioritization in order to make the recommendations. And I think this requires NITAGs. And if it is not really strictly evidence-based, you may see very haphazard recommendations of vaccines, again, dropping off the schedule, which is pretty much the worst that can happen. So I think it's a very, very important activity that needs to be conducted. And what we need collectively from all of us is, partner to help us with technical support, financial support, really to drive this agenda to an even more successful future. Thanks very much. These are my colleagues, Luis Hennaf and Christoph Steffen, who mostly work on this, and I really want to thank everybody here in the room and elsewhere to support us in this work.
Thank you. Are there questions for Dr. Hombach or Dr. Scheffer? Dr. Szilagyi.
Thank you very much. Does technical support include economic evaluation or, help with evidence to policy, economics, similar type of support, or what exactly is technical support?
I think it can also include economic evaluation. I think in terms of economic evaluation, we are very often in a situation that there are mathematical models, right? I mean, these mathematical models on the one hand side need to be populated with data, and on the other hand side, we need to have confidence and trust into the models. There's a little bit of work that is being done on our sides. There have been efforts like the PROVAC initiative and so forth. But this is clearly areas where technical support is helpful.
Other questions? Ms. Pellegrini.
So I'm going to go out on a limb here and say it sounds like we're a NITAG. Okay, but can a country...
That's how I should have answered your question, actually. We're a NITAG.
Can a country have more than one? So, for example, is NVPO also a NITAG?
I'll let Dr. Wharton answer that question.
So thanks for that question. The National Vaccine Advisory Committee really provides guidance about the overall program. It's not about specific vaccine recommendations. And at least the way I envision national immunization technical advisory groups, it's exactly the kind of work this committee does, where it's making specific recommendations about use of specific vaccines. So should HPV vaccine be added to a national program? And that's not the kind of work that INVAC does.
Any other questions?
Even though I think, in many countries, this distinction is probably not really going to make it's falling together.
Dr. Hunter?
It seems also, especially in the smaller countries, that the NITAGs are a lot more closely aligned with the actual implementation and financial decisions. and there's much more interplay between what are the resources of the health ministry and what's the advice going to be, then we are a little bit more separated from that because of the way the financing in the United States. Am I interpreting that correctly?
I mean, it's an important point. I think NITAG needs to be informed by the realities. And I think actually the last session that you had, on HPV for me, resonated already a little bit in this. It's not that you are here, so to say, in a bubble, you also connect to the realities, what it means in terms of financing and so forth. But I think there needs to be nevertheless some type of independence. So that the evidences, the science, the cost effectiveness come first, and then comes at the second step the issue of implementation and affordability.
Yeah, Dr. Moore.
Thank you very much for the presentation. I appreciate the value of NITAGs, after serving on this committee, the value of NITAGs around the world as we look at these more and more complex immunization policy decisions. A question for you is, how can the members of this committee be supportive of the work to expand this sort of expert advice around the world?
Well, let me think about a good answer. I think collectively, first of all of you, and also in your personal expertise, in one way or another, I'm sure are contributing or may be contributing. This committee is obviously a very functional committee, I think, from which other advisory groups that are, let's say, yet under development can obviously benefit a lot. So I think there could be, for instance, a strong element of peer learning, something that could be organized, and I presume is happening. I don't know. I'm looking to you, Abby.
Thank you. Yeah, I think there are a lot of opportunities. You're aware of some of these opportunities already to be of assistance to countries that are trying to develop something modeled on what we do. So I think there are opportunities. Do you want to?
And I just want to repeat into the microphone what Dr. Sheffer said for the webcast, that this committee, we're going to find opportunities. This is sort of an introduction of this issue, but to find opportunities for the committee to share expertise, to potentially do peer mentoring by setting you up with twinning and opportunities for you guys to help support training at your request and at your availability. But so you'll hear more about this in the future.
Yes, Dr. Bernstein.
Is there, so there's 83 countries that meet the 6 criteria to be a NITAG. Is the goal to have every country on the globe to fit those 6 criteria and be a NITAG? And who's guiding those groups from above?
Yeah, the goal is that every country has this capacity, absolutely. I don't think it's acceptable if countries take, so to say, decisions without having gone through a thorough process. As I've said, in some instances, this might actually be done through a more kind of a network approach where countries cooperate and collaborate. But for many countries, I think this is the objectives. Whether if it takes more time, then it takes more time. But I think it is an important objective to be achieved. And as I've said, we try to provide some global support through certain resources, networking opportunities, kind of a global resource center with guidelines and tools, with self-evaluation tools and so forth. But ultimately, these things cannot happen just globally. These things need to be fed and nourished also in regional and sub-regional structures. It's a long-term objective.
And we wish you great luck in achieving it, and we do stand ready to help in any way. Thank you so much, Dr.
Thanks very
Holmbach.
much.
This is really, really great presentation.